Assalamualaikum and a very good morning. A warm welcome to all participants from Malaysia, the SEAMEO network, the affiliated countries for today IMR-SEAMEO webinar. The theme for today is Understanding Cancer and Beyond. Our presenters today are from Cancer Research Center, Institute for Medical Research, IMR Malaysia. I am Dr. Nurul Ain and it's my pleasure to be your moderator for today's session. Ladies and gentlemen, I would like to take this opportunity to share that the aim of this webinar series, which are to share the knowledge, discuss the topic on biomedical research, and present the research outcomes, which is hoped to strengthen any future research collaboration with IMR. Please allow me to announce a few housekeeping messages from the Secretariat before we start with two interesting presentations today. The first one, we will not be taking any question during the presentation. However, the participant may ask questions using the link that we have shared in the email and in the YouTube channel. Second, we will have the question and answer session conducted right after both of presentation. Third, the attendance link is provided for those who would like to receive an e-certificate of attendance. It is available at the YouTube description section and also in the chat box, and you may fill in your particular using the provided link. Ladies and gentlemen, for today's webinar, we have two speakers from Cancer Research Center. The Cancer Research Center IMR consists of 3 units, which is Hematology Unit, Molecular Pathology Unit, and Stomatology Unit. Our first speaker is Dr. Robson Gubod, who is a dental specialist in Stomatology Unit under Cancer Research Center IMR. He holds Master in Oral Medicine and Oral Pathology from University of Malaya. His research area are in the area of oral lichen planus and oral lichenoid reactions. As for today, Dr. Robson will be sharing his experience with his talk entitled Oral Partially Malignant Disorder, Oral Lichen Planus. Dr. Robson, the screen is yours now.
Okay, thank you, Dr. Nurul Ain, for the kind introduction. Good morning to all participants. Thank you to the organizer for inviting me into this webinar series. My name is Robson Gubod. I'm from Stomatology Unit, Cancer Research Center, IMR. So today I will be sharing with you all on oral potentially malignant disorders and a little bit more into oral lichen planus. So, oral potentially malignant disorders, or in short, I will call it OPMD. It is essentially a group of conditions that may precede the development of cancer in the oral cavity. So, there are many types of OPMD as listed by the WHO. But the more common ones are leukoplakia, erythroplakia, oral submucous fibrosis, and oral lichen planus. So, why is OPMD important? Okay, this is because OPMD it can lead up to oral cancer. In fact, OPMD precedes most cases of oral cancer. And sometimes what we see as an OPMD, when it was biopsied, it has already turned into cancer. And the thing is, it is difficult to predict who will develop cancer after OPMD is detected. So these are the examples. In here, this is what we call as leukoplakia. It is a white plug in the mouth that cannot be wiped off. If it can be wiped off, it may be something else like fungal infection. And next, this one, this is a red patch in the mouth, or what we call as erythroplakia. This lesion, it can be painful or maybe not painful. And this lesion, it has a high chance of turning into cancer. Okay, next one, this is leukoplakia, which is a mixture of leukoplakia and erythroplakia, where there is a white patch and also red patch. Okay, next, this is an oral submucous fibrosis, which is caused by a recurrent eating habit. In this condition, patient can have a very limited or small mouth opening, and the surrounding tissue in the mouth, especially the cheek or the buccal mucosa, it feels very tight. This condition too has high risk of turning into oral cancer. Okay, the next one here is actinic keratitis. This lesion is usually on the lower lip, and it is caused by prolonged sun exposure. So OPMD, it can serve as an indicator of possibility of cancer developing in the mouth in the future, and also it can be painful and affect the quality of life. Okay, now we will zoom more into oral lichen planus. So oral lichen planus, it is a chronic inflammatory mucocutaneous condition with variable clinical presentation, and patient with oral lichen planus also can have skin lesion at the same time, and 60% of patients with skin lichen planus have oral lesion or oral lichen planus. Okay, next, oral lichen planus, it has a global prevalence of about 1.01%, and it is slightly higher among female. In Malaysia, a nationwide study done in 1997 showed that it affects about 0.38% of the general population, while another recent study in Cambodia, it showed that oral lichen planus is among the most common type of OPMD. So the exact cause of oral lichen planus is still unknown, but it was suspected that the cell-mediated immune dysregulation, where the T cells targets the stratified squamous epithelium. It was hypothesized that this is due to the presence of certain antigen in the epithelial cells. However, the nature of the antigen being targeted is still unknown. So, oral lichen planus, it usually appear on the buccal mucosa or the cheek of a person, on the side of the tongue or on the dorsal surface of the tongue, and also it can affect the gum area. And patients with oral lichen planus, they usually feel burning sensation, especially when they eat spicy food, such as curry. And this condition usually come and go, on and off. Okay, this is the most common presentation of oral lichen planus, where we can see white lines and or striations on the cheek. It usually affect both sides of the cheek. Okay, this example of the white lines or whitish striations. We also call this as a Wickham striae. Sometimes it can be pigmented, such as in the given photo. This is due to post-inflammatory hyperpigmentation. Lesion like this, it is usually asymptomatic and usually do not need any treatment. Okay, on the tongue, it will usually appear as a plaque. As you can see here, this is the normal surface of the tongue, and the affected area, they appear whitish. There's plaque present, and also a bit smooth and some depapillated area. On the gum, they also can have white lines or white striations, what we see here. And moreover, the gum can appear reddish, and this is what we call as a desquamative gingivitis. However, this desquamative gingivitis is not specific for oral lichen planus, as it also can be seen in other conditions like pemphigus. Okay, this desquamative gingivitis will become more severe and painful if the patient's oral hygiene is not good. Okay, this is how oral lichen planus usually appear on the lip. usually reticular striation or papule, white papules. So this is the erosive type of lichen planus. You can see that there is ulceration and surrounded by whitish striations, and sometimes they can be plaque also. This lesion is usually painful, and it has a higher malignant transformation rate compared to the lesions that I showed previously. Okay, in here I want to show the wax and wane on and off of lichen planus, oral lichen planus. We can see in this lesion there's a whitish spots or striations and papules, and then it become more flared up after 2 weeks. Usually this lesion will either develop ulcers after this, or it can reduce back to the original one. Okay, this is another example of the disease process, and an erosive type of lichen planus on the tongue. First appears an ulcer, very extensive ulcer, and then after treatment it will improve with reepithelialization on the surface. So this is an example of skin lesion of lichen planus. It usually appears as purple colored papules, and they can have white striations too. Okay, the skin lichen planus are usually very itchy, but they are self-limiting compared to the oral lesion, which is tend to be more chronic. Okay, to confirm the diagnosis of oral lichen planus, you will need to do a biopsy. This is basically what we see on the biopsy. There will be a band of lymphocytes underneath the epithelium, and sometimes there can be ulcers too. And then on the higher power, we will see that there is basal cell degeneration, and also presence of civet bodies, or what called apoptotic bodies. Okay, so now a little bit about oral lichen node reaction. This is a lesion that can mimic oral lichen planus, but this lesion is related to materials commonly like dental fillings, such as amalgam, or in patients taking certain kind of medications or drugs. So in here, like what we can see here, the whitish striations is just beside or adjacent to the amalgam filling, and sometimes this can be difficult to distinguish from an oral lichen planus. So we conducted a small research during my master program training, which was on clinical pathological study of oral lichen planus and oral lichen node reaction, where we evaluated histopathological features of biopsy cases and correlated with their respective clinical findings. So we found that the presence of eosinophils and higher plasma cells to lymphocytes ratio, it has a significant association with patients who are taking drugs or medications, and also patients with dental fillings adjacent to the lesions. So we thought that this outcome is helpful in designing the treatment approach and management of the patient. So both the oral lichen planus and oral lichen node reaction can transform into oral squamous cell carcinoma, which is what we commonly refer to as oral cancer. And there are some research have shown that most of them are systematic review, have shown that the oral lichen planus and oral lichen node reaction have a malignant transformation rate between 1.09 to 1.4 and 1.88 to 2.5 respectively. Okay, so this is an example of a case of oral lichen planus that transformed into oral cancer. Okay, this is erosive type of oral campinus on the tongue, and then the transformation was detected 7 years after the initial diagnosis. This is the area that has transformed. I think this is the area of the oral squamous cell carcinoma. So a little bit more on malignant transformation. The erosive type of oral lichen planus is the one that has the highest rate of transformation compared to the other types. And oral lichen planus on the tongue is usually requires more attention because malignant transformation usually the site usually involves the tongue. However, until now it is not entirely clear how the malignant transformation occur. And then it was also found that malignant transformation is higher among smokers and alcohol users. So in oral lichen planus patient, we usually treat them by first removing any local precipitating factors like sharp tooth that can rub on the lesion, and then after all the local factors are removed, usually if it is symptomatic or there's ulcer, usually it will be treated with corticosteroids, commonly the topical corticosteroids. But depending on the severity, sometimes systemic steroid is also needed. And also, patient is advised to avoid spicy or crunchy food, which can rub on the lichen planus lesion. But the treatment is not always needed. Like for example, in oral lichen planus that only has white striations, there is no need to apply medications unless it is painful. So, in conclusion, in summary, it is important to know that white or red lesions in the mouth can be an early sign of cancer. And also it is important to detect OPMD early and regular follow-up. This is to enable us to catch early sinister changes so that treatment will not be expensive or complicated. And also presence of OPMD indicate risk of future risk of cancer. So these are my reference, and thank you for your attention.
Thank you, Dr. Robson, for your interesting talk and also the interesting photos from your slide. And if there is any question that the audience would like to ask about his talk, kindly fill up the form that was given in the YouTube description link, and also in the chat box as mentioned earlier. So therefore, I would like to introduce our second speaker for today's session, Dr. Ermi Neiza Mohd Sahid. So Dr. Ermi is our pathologist specializing in hematology. She holds Master of Pathology Hematology from University of Malaya in the year 2017. Her research area are in the area of the hematological neoplasm, especially acute leukemia. It is our privilege to have Dr. Ermi with us today to share her work on the blood cancer and also the services that she provides. Her presentation will be entitled Acute Leukemia from Bench to Bedside. Over to you, Dr. Ermi. The screen is yours now.
Thank you, Dr. Ain, for your kind introduction. Good morning, everybody. Before I begin, I would like to thank SEAMEO Dropnet and NIH Malaysia for providing an opportunity for me to talk in this platform. My name is Dr. Ermi. I am a hematopathologist from Hematology Unit, Cancer Research Center IMR. So the topic of my presentation today is acute leukemia from bench to bedside. Okay, so this is the general outline of my presentation. Today, I'm going to share with you a little bit about acute leukemia and the journey of making an accurate diagnosis starting from the onset of clinical presentation of the patient to the multi-step process of the laboratory workup. My main objective is to explain how these test results are being translated and incorporated into the treatment of the patient care. As we go further later, I will be talking about the cause of acute leukemia, how the patient presented at diagnosis, and how we classify the types of acute leukemia. Later, I will be talking about the laboratory role and services provided in IMR for molecular leukemia diagnostic test. So, what is leukemia? Leukemia is a cancer of blood cells that develop in the bone marrow. It originates from the abnormal and immature blood cells which have undergone a malignant change and are unable to mature properly. These so-called blood cells multiply uncontrollably, crowding the bone marrow spaces, which then suppress the formation of the normal blood cells production and causing severe morbidity and mortality to the patient. Overall incidence in Malaysia is about 3.9% per 100,000 population according to WHO. Leukemia can be divided into acute and chronic. Acute leukemia occurs suddenly and very aggressive disease, while chronic leukemia causes accumulation of more mature but abnormal white cells that can function normally up to certain point of time. As I said before, acute leukemia is an aggressive disease. How we diagnose acute leukemia? According to WHO, when there is a presence of 20% or more blasts out of 500 bone marrow cells, we can call it acute leukemia. Secondly, if there is presence of recurrent genetic abnormalities, the diagnosis can be made regardless of the number of blasts. Acute leukemia requires immediate treatment. Generally, acute leukemia can be divided into two types according to the cell lineage. There are acute lymphoblastic leukemia and acute myeloid leukemia, as you can see here. The differences is the appearance of the blood cells, characteristics, and features. So the treatment will be different. This slide here is to show you an overview of blood cells development. The hematopoietic cells reside in the bone marrow, and they have a unique ability to differentiate into diverse mature cell lineage. Here, the hematopoietic stem cells, it can give rise to two main daughter cells, which are common myeloid progenitor and common lymphoid progenitor, which in turn are the basis of all blood cell types. The hematopoietic stem cells are multipotent and have the capacity to differentiate into the cells of all 10 blood lineage, such as erythrocytes, platelets, neutrophils, eosinophils, basophils, monocytes, T and B lymphocytes, natural killer cells, and dendritic cells. So, what is the cause of acute leukemia, you may ask? In general, the cause of acute leukemia is still unknown. Some genetic and environment factors have contribution roles, such as intense radiation, chemical exposure, such as benzene, and certain viral infection can also cause acute leukemia, for example, human T-cell leukemia. At the cellular level, many studies discovered series of genetic alteration, for example, mutation in oncogenes or loss of tumor suppressor genes, in hematopoietic precursor cells can lead to development of acute leukemia. Our DNA contains the instruction that tells a cell what to do. Normally, the DNA can tell the cells to grow at set rate and to die at a set time. However, in leukemia, the mutations tell the blood cells to continue growing and dividing. When this happens, blood cell production becomes out of control. Over time, the abnormal cells can crowd out the healthy blood cells in the bone marrow, leading to fewer healthy white blood cells, red blood cells, and platelet, causing signs and symptoms of leukemia. As the new technology advances, more recurrent gene mutations can be explored and can be used for risk stratification and treatment guidelines. This can help us to develop the gene mutation targeted new drugs and therapies. These are clinical presentations of acute leukemia. Okay, the symptoms of leukemia in the patients can be attributed to the suppression of normal blood cells. In healthy subjects, red blood cells carry oxygen around the body. White blood cells can help us to fight infection and as the immunity barrier for us. And platelet can help us in stop the bleeding and coagulation. So the clinical presentation of acute leukemia results from infiltration of the bone marrow or extramedullary-cytes by blast. Increase of the blast will cause the initial symptoms such as you can see here, weight loss, fever, frequent infection, and then after that, patient may have anemia or low red blood cells, neutropenia, low white blood cells, and thrombocytopenia, low platelet. So this will cause symptoms such as mucosal bleeding, petechiae, hemorrhage, and also bone pain. Now we go to the classification of acute leukemia. The current classification of acute leukemia is based on the combination of clinical presentation, morphological appearance of the cells in the peripheral blood cells and also bone marrow aspirate, immunophenotyping, and also molecular genetic features. This slide might be overwhelming to you, but I will try to simplify it as simple as possible for better understanding. In the revised 4th edition of WHO classification published in 2017, acute myeloid leukemia can be classified into 6 categories. Okay, this is the long list of types of acute myeloid leukemia. So, first classification is myeloid leukemia with recurrent genetic abnormalities. What is recurrent genetic abnormalities? It is an abnormality that shares part of abnormal sequence in other abnormalities that have been reported in at least 5 different publications. Okay, other types of acute myeloid leukemia are AML with myelodysplasia related changes. Thirdly, therapy-related myeloid neoplasm. Acute myeloid leukemia not otherwise specified, or NOS. Myeloid sarcoma, which is accumulation of the blast cell in the tissue. Myeloid proliferation related to Down syndrome. For this group of acute leukemia of ambiguous lineage, this is the types of acute leukemia that in which the morphology, cytochemical, and immunophenotypic features of the blast does not allow classification to be myeloid or lymphoid. So they might not have any of the features, or they have both of the features. acute lymphoblastic leukemia. This is the malignant transformation and proliferation of the lymphoid progenitor cells. Occurs in mostly 80% in children. It represents the devastating disease when it occurs in adult. So it is more of children's disease, and more severe if it occur in adult patient. 75% of cases develop from precursors of B-cell lineage, with remainder of the cases consisting of malignant T-cells precursors. Okay. How we diagnose acute leukemia? This is the common or standard workflow for laboratory diagnosis of acute leukemia. Generally, in the most clinic and center, the first important test to do is full blood count. This is to see if there's any abnormality in the proportion of blood cells. If leukemia is suspected due to high white cell count or pancytopenia, which is very few blood cells present, we then will do full blood picture. This is blood smear. We smear the blood on the slide to see the morphology or the looks, the appearance of the blood cells. We can see roughly what is the type of leukemia from the full blood picture. But for further confirmation, we will do bone marrow aspirate and refined biopsy. Here, we can establish diagnosis of leukemia by morphological appearance, and we can stain using immunohistochemistry to confirm the types of leukemia. Flow cytometry or immunophenotyping can be used to help to distinguish AML from ALL. It detects the type of cancer based on the presence or absence of certain protein marker or antigens on the cell surface. The identification of these leukemia cells by the immunophenotyping can help us to monitor the minimal residual disease during the therapy. Cytogenetic or karyotyping is an individual collection of chromosome. Cytogenetic test is a laboratory test technique that produces the image of individual's chromosome. The karyotype is used to look at for abnormal numbers or structures of chromosome in acute leukemia patient. This will influence the diagnosis and prognosis of the disease. For molecular tests, I will explain later. So what we can see here is the evolution of molecular diagnostics in hematology. First test that we use in early 19th century is microscopy. So as I explained before, microscopic test is just to see how the cells looks like. So we can see roughly whether the blast is present or not. And after that, we have technique called cytogenetic or karyotyping and also immunohistochemistry. This also involves microscopic examination of the chromosome of cancer cells. The example of chromosomal changes that we can see in leukemia can be deletion, which is missing of the part of the chromosome, translocation, where the two chromosomes can be exchanged, additional or duplication in the chromosome, or trisomy, where there is 3 copies of the chromosome rather than 2. After that, we have immunohistochemistry tests. In flow cytometry, the bone marrow or peripheral blood cells are coated with antibody to look for the presence of the certain protein, which help us to classify and identify the type of acute leukemia. In fish or fluorescent in situ hybridization procedure, we use special dyes to look for changes in specific genes. The very famous example is in chronic myeloid leukemia. Chronic myeloid leukemia is not acute, but as an example, we can see in fish pieces of the BCR-ABL1 fusion gene on chromosome 22 or Philadelphia chromosome. The latest technology, molecular, is PCR, whereby this is a sensitive tool for diagnosis and also monitoring of the minimal residual disease that can help clinicians to manage and treat the patient. Okay. The very latest and up of state diagnostic tool is NGS or next generation sequencing. This can reveal the rising number of somatic mutations that help to determine both phenotypic and prognostic heterogeneity of acute leukemia. Why we go for molecular tests? We have seen impressive growth and development in molecular diagnosis in the last 25 years. So management of individual cancer patient is increasingly influenced by specific features of the tumor and due to specific genetic alteration. Therefore, molecular and genetics play a very crucial role in diagnosis and prognostication of the hematological neoplasm. What is the concept of precision medicine? Precision medicine are meant for personalized treatment, targetable genes, and availability of drugs, which is we call targeted therapy for specific disease for specific patient, and also for disease monitoring. Now we go to our services in IMR. We provide a molecular hematology service. Actually, we have 4 tests as general. Leukemia translocation study, acute myeloid leukemia mutation study, chronic myeloid leukemia mutation study, and chimerism study. But today, I'm only will be discussing on these 2, which is related to our topic, translocation study and also mutation study for AML. What is leukemia translocation study? This study can identify 30 chromosomal translocation using real-time qPCR. We use commercial kit Q1DX. Actually, we did pilot study on childhood leukemia translocation in HKL from 2008 to 2011. So this test was offered for the whole country for pediatric and adult since June 2012 till now. Okay, these are the list of what we can see from our test. This is the fusion gene that can diagnose what type of leukemia you have and what sort of treatment that the clinician can plan after the patient diagnosed to have this fusion gene. Okay, this is just to show you the fusion genes that we detected since 2008. So what you can see here, the biggest portion is actually BCR-ABL or Philadelphia chromosome translocation of 9 and 22. Commonly, this is the hallmark for chronic myeloid leukemia. However, patients with acute leukemia, especially in pediatric, can have pH positive this translocation, and it shows poor prognosis in the disease itself. So total number of the cases that we have run so far is about 4,440 for the whole country. So here I just want to show you how our staff do the RNA extraction for molecular study. This is how they prepare the sample for PCR. And after that, they will perform the 30 leukemia fusion genes screening kit. And lastly, they will perform the analysis using the bioanalyzer before the result come out. This is just the automated extraction of DNA. So the other test is acute myeloid leukemia mutation study. This test can help to manage the patient of AML for diagnosis and prognostication purpose. Molecular mutation have been analyzed to subdivide the AML into prognostic subsets. This test was offered since October 2013. These are the genes that we detect in our test. Most importantly is FLT3. We have also NPM1 and c-KIT and also CEBPA. This is all done by PCR and also sequencing. It is very important to detect these genes because this will determine the severity of the disease and the different treatment that clinician can offer to the patient. For example, FLT3 can cause patient with AML to have poor prognosis. This is just the algorithm of acute myeloid mutation study. For all acute myeloid cases, we will do FLT3 first, then we will proceed accordingly, according to what we need. What is the clinical application of molecular technique and genetic markers in hemato-oncology? It is for initial diagnosis, when we detect the fusion genes and the mutation. Then it is for establishing a treatment protocol, so clinician can do risk stratification. They can say which patient have a good prognosis and bad prognosis, and also to monitor the response of therapy. Okay, overview of the common treatments for acute leukemia. So nowadays they will give chemotherapy as first line, and then targeted therapy. Some of the acute leukemia can receive radiation therapy. For example, patient of acute lymphoblastic leukemia with brain metastasis, so they will radiate the brain. And the gold standard is actually bone marrow transplant. And this is also done for patient with poor prognosis. And the latest treatment is immunotherapy. For example, CAR T-cell therapy, which is chimeric antigen receptor. We engineered, personalized the cell to fight the leukemia according to the patient. And clinical trials is only offered for certain patient, not for the purpose of wide marketing. This is just the risk stratification by the standard European Leukemia Net in 2017. From the genetic findings and molecular findings, they can stratify the patient into favorable, intermediate, and adverse patient, and the treatment is also can be differ. This is the precision or targeted therapy. You can see our finding of the molecular test. From here, we can target directly the cancer cells according to what we have, like FLT3. So we can inhibit the marker for FLT3 in the cells, so that the cells cannot divide and become worse. When they receive this kind of treatment, it is more accurate. This is the precision medicine in acute lymphoblastic leukemia. For future tests, basically it is the next generation sequencing, and it comes in many packages such as whole genome sequencing, whole exome sequencing, and targeted sequencing. So in IMR, we use targeted sequencing to identify the specific genes. So this is just the workflow of targeted sequencing. And lastly, I just want to show you some of among the research works that we have done in IMR. So we have a lot of ongoing research in acute leukemia. So this is just the past research work that we have done. So we hope that we can have more collaboration with other people later for leukemia work. So I think that's all for my presentation to do. Thank you very much.
Thank you, Dr. Ermi, for the insightful presentation on this complicated field of blood disorder on leukemia. So we will be moving for the question and answer session. To all participants, please keep sending us your question through the Google form or in the YouTube chat box, and I'll be picking a few questions to ask our presenters. It seems that we have received quite a few questions from the audience from the Google form. Let me pick a few questions. So, Dr. Robson, so there is a question to you from Dr. Asri Abdul Rashid. He asked two questions. Question one, when it comes to actinic keratosis, is there higher rate among fishermen and farmers than the white-collar individuals? And second question, are there any specific biomarker of early detection of OMPD?
Thank you for the question. So for question number one, actinic keratosis, is it higher among fishermen and farmers than the white-collar individuals? So actinic keratosis is a type of OPMD. It is mainly caused by prolonged exposure to sunlight, especially on the region of the lower lip. So for this question, if the fishermen and farmers, they have more prolonged exposure to sunlight, then they will have more risk of developing actinic keratosis than the white-collar individuals. And then for the second question, specific biomarkers for early detection of oral potentially malignant disorders. So far, they have tested multiple biomarkers. They are still searching for biomarkers that can help in the early detection of OPMD. However, unfortunately, we are still currently there are still no specific biomarkers that can help for the early detection of OPMD. The early detection of OPMD, the most important thing is the clinical findings. It has to start with the clinical findings, and the individual or patients must be aware of the type of OPMD that can occur. And in terms of like molecular, in general now they're considering things like aneuploidy or loss of heterozygosity to have higher risk to develop OPMD or OPMD to turn into cancer. Thank you.
Thank you, Dr. Robson, for answering the question. So we got also a question to Dr. Ermi. So the question is from Azian Naila Muhammad Noor. So she asked if can acute leukemia occur in children? Any comments on that?
Yes, acute leukemia of course can occur in children. In fact, leukemia is actually the most common type of cancer in children, and about 80% of acute leukemia is in children is acute lymphoblastic leukemia, and it is common in early childhood, peaking between 2 to 5 years old, and AML tend to occur in more older children. Yes, of course it can occur in children.
How about which age group will have the highest prevalence of leukemia? This question is actually from Shima. So Shima asks which age group have the highest prevalence of leukemia?
When you refer leukemia, you must define whether it's ALL, acute lymphoblastic, or AML. For ALL, the peak age is around 2 to 5 years old. And for acute myeloid leukemia, it is more diverse according to the type of leukemia. Some people can have acute myeloid leukemia in early age. For example, acute subset of AML like APML, acute promyelocytic leukemia, which is the most aggressive type of leukemia, usually occur in young adult. And the other type of myeloid leukemia usually occur in older age group and also older adult.
Thank you, Dr. Ermi. So I will forward next question to Dr. Robson. So Dr. Robson, we have question from Nurul Aina Khalid. So Nurul Aina asks, does oral fungal infection looks the same as OLP? And if it is, how do we differentiate between them? Is it common in children or babies?
Okay, thank you again for the question. So, oral fungal infection and OLP, for those who are used to see it, they are different. But sometimes, if we are not used to seeing this kind of lesion, we can be confused. But basically, oral fungal infection, if you want, one of the way you can help that can help to confirm it is you can try to wipe on the lesion. If the lesion can be wiped off, then it is not an OLP. It is most likely an oral fungal infection. And then OLP, it usually appears as a lines, white lines, while oral fungal infection, it usually appears like a plaque, like a small patch, like 1 to 2 mm in size. And however, OLP can have fungal infection. So yeah. And then I've answered how to differentiate between them. Okay, is it common in children or babies? OLP is very rare in children. It's very rare. It's usually among adults, but there has been reported cases among children, but it's very rare. That's all.
Thank you, Dr. Rosa, for answering. So, Dr. Ermi, we still have few questions to you. So, this is from Norizan. So, she asked, is leukemia a curable disease? Can we cure them?
Well, leukemia is a cancer. So, with current advance in treatment, we have 65% to 75% people in acute myeloid leukemia to reach complete remission. Remission is a state where after the diagnosis and treatment, the leukemic cells cannot be detected molecularly in the body. So that is kind of a very good statistic already. And for certain type of leukemia such as APML or acute promyelocytic leukemia, the chance to have a curable remission is very high due to the introduction of ATRA a long time ago. So the current remission state for APML is now about, we can say, 80 to 90%. However, for this patient, generally speaking, AML, which have quite more challenging treatment for them, the cure, not to say the cure rate is actually lower, especially patient in the older age group, more than 60 years old. There is also a term of relapse, which in some leukemia patient, after they reach remission, that we can call cure for sometimes, they can have again a relapse of the disease. That's why we need to monitor them closely, so that by molecular tests we can pick even the earliest sign of relapse in a patient with remission. I hope that answers your question.
Thank you, Dr. Ermi. I think because of the time constraint, I will only take one more question. So it is for you, Dr. Robson. Final one from Dura Zambri. So Dura asks, what are the warning signs of OMPD that public should be aware for them to seek medical dental attention?
So basically, every OPMD, people should seek medical or dental attention, and the basic things that people can look at is white patch, white striations, or any white lesions in the mouth, or red lesions in the mouth, red patch, red lesions, and more importantly, if there is ulcers in the mouth that does not heal or does not improve after 2 weeks. All these pictures, it is strongly advised for people to seek medical or dental attention. Yes, that's all.
Okay, thank you, Dr. Robson. So I'm afraid that is all the time that we have for this question and answer session. So for those on unanswered question, our speaker will reply to your question personally to the email, because we get your email address from the Google Forms. And therefore, thank you for your participation in the Q&A session. So we hope that this webinar has shed some light on some of the research work and also the service that we are conducting at the Cancer Research Center IMR, that include the intervention, prevention and diagnosis, and maybe it will spark the interest that will initiate some collaboration with us for the future. So ladies and gentlemen, we have now come to the end of our webinar session. I would like to thank all participants for their support to make this session successful. You may like, subscribe and share of our National Institute of Health Malaysia YouTube channel and click for notification wherever there is a new post. For your information, we will update you with the details of the upcoming webinar session through the email. Until then, many thanks from us, from Cancer Research Center and IMR and also SEAMEO. Take care and stay safe. Bye.